And that's but one example.
Well, let me ask Dr. Smitherman to join in here, and if you would, Dr. Smitherman, sort of explore and stretch out on the conversation we've had so far. What are the challenges, what are the reasons, the good reasons for a pay for performance model, and again, what are the dangers for the audiences, the customers that you serve?
Okay, first of all, pay for performance. The definition simply is we're talking about a healthcare payment system that in hospitals for reaching certain target quality standards. So, for example, let's take a very simple example as a physician. What's called a hemoglobin A1C, and this is very simple. It's just a average level of blood sugar that we measure and reflects whether the patient's blood sugar has been controlled over the previous 2 to 3 months. So the higher the value, the worse their blood sugar control. The American Diabetes Association uses the value of 7 and below is a good value. The American College of Endocrinology uses 6.5. The reference range is from 4 to 6. So first of all, we can talk about other societies that have target quality standards. So first of all, there are several standards. Second of all, let's say I'm in a wealthy, healthy suburban community, and I start off as a newly diagnosed diabetic with a hemoglobin A1C of 8, and the target standard that the insurance company wants to pick out of the several different standards will pick the ADA standard of 7. So for that suburban newly diagnosed patient, they have to go from a 8 to a 7, whatever this financial reward. I'm in an urban setting where average hemoglobin A1C start at 12. I go down to a 9. I have actually had a 25% reduction as compared to a 10% reduction in the more healthier, wealthier suburban community. I've done more work. I won't receive any reimbursement because I have not reached the 7. It means that if you talk about communities that, for example, have 26% higher poverty rates, they have prenatal care that's inadequate, 20%. They have 126% higher low birth weight babies, infant mortality rates at 300% higher, chronic disease levels of 22 to 78% higher, death rates of 30 to 100% higher. I think you get the picture. We're starting at a different baseline that I may actually do 25 to 30% more work and effort to reach whatever the number or value or standard I reach, and it might not be the actual target standard or established target standard that the insurance company employs. What it means is that you may penalize practices that have more complex patients, that have poorer patients with less resources, that have sicker patients, that have vulnerable patients. You will penalize and disenfranchise providers who are providing care to the toughest population. And I can tell you, if you're really interested in something that talks about standards and performance, if you're attempting to equally value and the most vulnerable populations as compared to the healthier and wealthier populations, that's the core problem with pay for performance. When you want to implement a financial reward system prior to putting into effect the infrastructure that's needed to acquire the data, the quality data to support that system, then you're really talking about cost containment as opposed to appropriate and improved care and quality. Now, we've had cost containment models. That's what managed care was. That's what prospective payment was. These were cost containment methodologies. If the issue is cost containment, which I believe it primarily is, then we ought to be upfront about that. Because if you're going to talk about quality, we first have to establish how we're going to actually even collect the actual data to do the comparison. Most physicians in the United States do not have electronic medical records. Only 17% do. We have paper charts. all of the important clinical and quality data to even do comparisons.
I'm Al McFarlane. You're listening to Conversations with Al McFarlane, broadcasting this morning from the Minneapolis Urban League in North Minneapolis. Our conversation is health, pay for performance. And you've heard Dr. Herb Smitherman from Wayne State University, and prior to him, Dr. Gary Puckrine from the National Minority Quality Forum. And so let me ask you gentlemen to continue, and thank you for explaining the issue, but to continue in that explanation. On the one hand, there is value in accountability. I think our society, American society, is demanding transparency, accountability, and I think nobody can disagree that cost containment is something that we have to all be concerned with. But you raised the question, Dr. Smitherman, do we focus more on cost containment, or do we focus equally or put in the equation the primary mission of health and wellness? And so where does the notion of creating a health conscious, successful health environment come into this discussion of cost containment? How do you weigh health and cost containment?
Yeah, I think we want the best possible care, the best outcomes. We want to get the care people need in a manner that most effectively protects and restores their health. So we want high quality, efficient cost. The issue is that we don't have the data in place right now that actually proves that pay for performance actually improves quality. So I think that's the first step. We don't have the data that actually shows it actually decreases costs, because the actual ramp up of the administrative costs required to implement the pay for performance payment system, actually in some studies shows that it negates any cost improvements on the clinical side. So if the objective is to improve quality and decrease cost, I'm not sure this methodology will work. I'm not saying that it won't, and we do need accountability, but let's just talk about data collection. We've got to have methods to have the capacity to have accurate information so that we can actually in a valid way, in a reliable way, basically clearly understand that the care that has been provided is truly quality. If right now, almost 90% of providers actually are using paper charts to document their information, that means if you're going to go in and try to determine whether blood pressure outcomes were reached, or whether you have diabetic outcomes, or whether you have prostate cancer, colon cancer, mammography, whatever, pap smears, etc., you actually have to manually go into each individual charts and pull out that information. You actually need to do this electronically, but we haven't implemented that resource within our community. For example, the United Kingdom actually a pay for performance program instituted in somewhere around 2000 or so, where the first step they did was implement an electronic record across their system. Secondly, they actually put the resources up front so that the primary care physicians could actually have the appropriate reimbursement in place, so that when they met the goals and targets, that they would actually get the rewards. So all I'm saying is we have to make sure the infrastructure is in place so that understand we're measuring the exact information and the performances and that we actually want to promote.